with the renal failure also. So benzodiazepines have been used effectively as a muscle relaxant because it acts on the glycine receptor in the spinal and the supraspinal sides, and it has cardiovascular and the respiratory depression effect. So even after stopping sedation infusion, this patient will have hypotension, this patient will have respiratory failure, this patient will have CO2 retention. So frequent monitoring of these patients is required. Midazolam, uh, we need to understand the pharmacokinetic variability, because in obese patient it will have extended duration of action and patient will have residual sedative effect. So that's why half-life of midazolam is prolonged in the ICU, which may be similar to lorazepam, may go up to 10 to 20 hours, though it is short-acting agent, but it can become long-acting agent, especially in patients where we have used it as a continuous infusion. And as I have already discussed, the plasma of midazolam decreases more after discontinuation of drug administration compared to lorazepam. But the effect of lorazepam is short-lived than midazolam because the concentration of this drug is in the fatty tissue is less compared to midazolam. So as we know, the midazolam is metabolized. Okay, it causes inhibition of metabolism of several drugs like propofol, diltiazem, some macrolide antibiotics, and because it activates cytochrome P450 and enzyme 34A. So that's why in these patients, the prolonged action may be possible because it inhibits metabolism. So that's why whenever we use benzodiazepine for drugs, the doses has to be titrated according to the sedation. We need to know what is the endpoint, till how long the patient has to be given the sedative agents or benzodiazepines. As long as the drug dosages is adequate enough, the further dosages should be avoided. And if the patient requires frequent dosages of these benzodiazepines, then continuous infusion can be given in these patients. So continuous infusions has its own disadvantages, that it may have accumulation of the drug in the fatty tissues. As far as the propofol is concerned, it is general anesthetic agent. It is rapid, rapidly acting drug with a short duration of action. It is also called a street smart. The street fit drug can be used for daycare procedures, and then. But even in its context half-life is 45 hours, 45 minutes. If it is used in continuous infusion, and its metabolism gets unchanged in patients with the renal or hepatic dysfunction. So that's why in critically ill patient, continuous infusion of propofol, and then depending upon the size, especially because it being it has the fat content also. So this preparation will have prolonged effect, especially in patients with the obesity. Prolonged effects can be seen. Ketamine is another analgesic and sedative agent, which is a phencyclin derivative. It acts by NMDA receptor stimulation and releases catecholamine. That's why these patients will have tachycardia. And it also has bronchodilatory effect. So in severe asthmatic patients, this will be a best bronchodilator, but it causes hallucination because it causes dissociation of limbic system with the cortical system, and that's why patients will have hallucination. So in patients with a propofol, patients should be monitored for acidosis and propofol infusion syndrome and acute renal failure. For ketamine, the patient should be monitored for hallucinations. So clonidine is also another agent which is used for augmenting the effects of general anesthetic agents and narcotic agents, and it is also used in withdrawal syndromes. So dexmedetomidine is another sedative and analgesics sparing activity, and the patient remains sedated when undisturbed but aroused rapidly when patient is given some stimulus. So it produces anxiolysis, which is comparable to benzodiazepine, and it has rapid onset of action, and blood pressure also, tachycardia also gets controlled. Okay, and then it may cause hypotension if the patient is hypovolemic. So as far as so these agents are concerned, Haloperidol is quite commonly used, and chlorpromazine is also used. So basically, in patients with the delirium, especially with the hyperacute delirium, these preparations will stabilize the cerebral function by antagonizing the dopamine receptors, and it also inhibits the hallucinations, delusions. It also has sedative effects. So, as far as haloperidol is concerned, it has lesser sedative effect and low risk of hypotension than chlorpromazine, but it has long half-life. Okay, so the dose has to be 2 milligram bolus, followed by repeated doses depending upon the response to the treatment. But it also has adverse effects of QT prolongation.